maker. So Dr Adnan, Abdallah, Hussein. So ureteric erosion caused by migrated intrauterine device. Let's see about that.
Hello, good morning all. Today I have a case about a typical clinical manifestation, diagnostic challenges, and therapeutic dilemma of an unusual case report caused by migrated IUD. I'm Adnan, urology resident in National Institute of Urology and Nephrology there in Cairo. Conflict of interest is institutional, and we have in literature just only 3 reported cases about migrated IUD causing an erosion or destruction or injury of the ureter. Yani from the uterus going back to the retroperitoneum and making injury of the ureter, which is very, very rare. So, as we know, IUD is one of the most frequently used contraceptive device and it's safe. But making perforation of the uterus is a rare complication, and such perforation of IUD may migrate to the adjacent pelvic organs is very common. So as a urology, we usually see migrated IUD making injury in the bladder, and on the other side making injury of the bowel, and etc. So an injury or obstruction of the pelvic ureter, subsequent making hydronephrosis, it's very extremely rare. Our case report is about a 26-year-old female came to our emergency department with complaint of intermittent right iliac pain since 3 weeks. She has a history of 2 vaginal deliveries, and they fixed IUD 2 years and a half ago. And she was having a regular menstrual cycle. On abdominal examination, there was a right lower quadrilateral tenderness, while vaginal examination was normal. She underwent non-urological surgery, which was tonsillectomy. Her laboratory investigation was normal. And she previously visited general surgery and obstetrics and gynecology clinics, and they suspected it can be appendicitis and it can be ovarian pathology, which was queried. And ultrasound report that we did in our institution, transvaginal and transabdominal, revealed that there was a displaced malpositioned IUD, which transversing the uterus and indenting the right distal ureter, forming a large heterogeneous multi-septated cystic collection, which was most probably urinoma. And our radiology department suggested to do a CT-UT. And as you see here, non-contrast CT-UT revealed that there was a right hydroureter nephrosis, and there was, as you see, the lower part of the right iliac fossa in the IUD, we can see clearly in the axial view. Our patient told us that she missed the follow-up of IUD and she never tried to fill the string per vagina. And here we have the IVB film. You see the right kidney, there is a very delayed excretory phase of the contrast. It's about 2 hours and still there is a contrast in the right kidney, which dictates that there is obstruction. And this is the report, evidence of moderate dilatation of the right pelvic ecclesial system with whole right ureter till the distal portion ending with a small cystic contrast fillet, localized collection related to a malpositioned IUD, which we confirmed by ultrasound. So there was no evidence of distal ureter continuation to the right vesicurhital ureteric junction or extravasation. Probably it's a distal ureteric traumatic injury with urinoma formation. And the surgical intervention we did for her, a diagnostic cystoscopy, which was no abnormality seen in the bladder, and the diagnostic ureteroscopy failed to introduce the guide wire in the right ureter due to the obstruction beyond the perforated arm of the IUD, which we confirmed the retrograde urography study. As it was not feasible to remove it endoscopically, and there was a high chance of concomitant injuries, we proceeded to the explorative lower midline laboratory And interoperatively, we saw that there was an ill-divided adnexa resulted from the long-standing urinoma and fibrosis bandis at the right iliac fossa. Uterus was intact, no perforation, and interoperative, we requested a general surgery and gynae consultation, and both of them, they recommended to conserve follow-up respectively. We proceeded hard to removal of IUD, excision of the erosion or structure part of the ureter, followed by right double J stent insertion, and we did a uretero-ureteral anastomosis. Drain and ureteral catheter was fixed. As you see here, I don't know if you can see very clearly because there was a difficulty to take the pictures as clear. So this is a fibrotic ureteric segment, and after transecting, this is the distal part of the ureter, and we did uretero-ureterostomy. So postoperative day 1, KUB is over here, and then postoperative follow-up was uneventful, and catheter was removed after 10 days, and double J removed after, it was about 1.5 months, and our patient is symptom-free at present, and we have been asked to follow up closely. So IUD is widely accepted contraceptive method among women for many years due to its efficacy, longevity, and reversibility and safety. Being foreign body, it can dislocate, erode, and perforate the uterus and can migrate to the extrauterine. So uterine perforation is an uncommon but serious complication occurring in up to 1 of every 1,000 cases. So the risk increases especially in these conditions like postpartum, recent abortion, midterm pregnancy termination, or following cesarean section in sepsis and multivara. Perforation might be most frequent with copper IUDs, and studies suggest up to 15% of perforated IUDs may cause injury to the surrounding organs, most frequently the bowel. Why we choose this case? IUD migration to the ureter and causing ureteric obstruction is very rare. And as I told you, we find only just 3 cases in the literature worldwide. So in the light of our finding, the uretero-ureterostomy or uretero-neocystostomy may be a better option to relieve the ureteric obstruction caused by migrated IUD. And conclusion, so first we must do sonographic evaluation of IUD position after 2 to 3 months. In the string is not found, urgent abdominal radiography, ultrasound should be done. Any case of IUD migration should be dealt as an urgent, and the treatment should include surgery for the extraction of the device, and the patient should be followed up for a possible formation of ureteric stricture on the long run. And here our institute building. Thank you.
Could have been worse, pregnant on top of all this.
Let's one question, please.
There is one question.
Because we always forget. Thank you very much. I'm very sorry.
All of these cases is very good, but the message to do ureterostomy for you and for all the audience in such lower share is accepted. Ureterostomy.
It depends where the location. In this case,
I think it's
Yes.
in this location, having a reimplant is much easier.
for sure.
Yeah, and my answer about this question is, you are right, ureterostomy in distal ureter is not a good option. But why we did, especially in this case, because there was a 10 centimeter proximal to the bladder. So we tried our best to do uretero-neocystostomy, but the distance was some sort of very far, and my consultant take the decision to make a uretero-ureterostomy instead of uretero-vesical reimplantation. Thank you.
Thank you. Next speaker.